Hello, friends. I extend a very warm welcome to you for this session that we have this symposia on the burden and the impact of the human immunodeficiency virus, better known as HIV, on elder persons. So in this symposia, we have three speakers who are going to talk on different aspects of the HIV virus and the older person. First, myself, I am a professor of medicine and I work at the institute in India in the state called Punjab. And we have data from our center, which I will be presenting during my presentation. My colleagues, Dr. Alpana RAIZADA is at the University of Delhi, and Dr. Meenaxi is also a professor of medicine at the University of Rajasthan, which is a state in India. So I welcome you once again. Thank you for joining us for this symposium. And I will now next talk about the service utilization of older persons in our health service that we provide for the HIV positive patients. In today's presentation, friends, I'm going to talk about service utilization by older persons at the antiretroviral therapy center that we run at a large public hospital in New Delhi at our hospital. This is a retrospective analysis of data from our center over the last 15 years, and I'm joined by my colleagues, Dr. Alpana RAIZADA and Shweta Jain, in development of this presentation. So I will cover this talk under 5 different subheadings, including the background, the aims and objectives. I will talk about how the methods we used, the observations, and finally, the conclusions from our study. As has been established, the share of older persons living with HIV across the world has been increasing. Definitely, due to the success of the antiretroviral therapy, we have seen that more and more people living with HIV live beyond the age of 60 years, thereby increasing the number of people over 60 years of age who have HIV. In addition, newer infection in older persons has also been seen to increase over the last few decades, and the number of women living with HIV in 60 plus age group has been found to be increasing rapidly, much faster than the 30 to 49 years age group. Definitely, HIV in older persons is very different from those who are younger. There is a delay in diagnosis because the healthcare workers usually would not suspect infection in the older persons and hence will not test them for HIV. Comorbidity is important, and the older persons over a period of time will accumulate health deficits and they will have multiple comorbid illnesses along with HIV, and it's never pure HIV that is a presentation. Definitely, it has also been seen that CD4 counts are lower at the start of a heart or the ART therapy in older patients as compared to the younger ones. And the increase in CD4 counts after initiation of antiretroviral therapy is also much lesser in the older patients as compared to the younger patients. There are age-related differences in the immune response to HIV and ART, and definitely all this, the poor outcome or the chance of poor outcome in older patients who also, in addition to AIDS-related complications, have many non-AIDS-related complications, which will add to the cause of a poor outcome in these individuals. The impact of HIV in older persons has not been very well elucidated in India, and hence we decided to do this study in which we recorded the trends in service utilization by older persons at our center. We wanted to study the trends in utilization of healthcare services, and we wanted to study the differences in presentation among older persons as compared to the younger persons. We tried to find the proportion of people living with HIV who were older and who used the services at our center. And we tried to determine the mean CD4 counts at presentation and the mean viral suppression or the viral load at the presentation in older persons and compare it with those who were younger and presenting with HIV. We largely did a retrospective analysis of the service data at our center, and we had the data between the years 2005 and 2020, which was reviewed retrospectively. We took care to maintain patient confidentiality, and we removed any unique identifiers before the analysis of data was attempted. 1,329 people who were registered at our center for treatment and care over the last 15 years. The distribution of sex and gender in these individuals, there were 65% men, 32% women, and around 2.5% who were transgender in the entire subset. We realized that 353 persons were older than 60 years of age in the group, and the 12,976 individuals were younger than 60 years of age. This is the number of registrations that we had over the 15-year period that we made the study. And this is a histogram, a frequency histogram of all the patients who got registered at our center from the year 2005 until the year 2020. This histogram depicts the frequencies of the older persons who got registered at our center. And in this histogram, I have presented the frequencies of older women who got registered during this period in our center. So over the years, we tried to study the mortality among this group of individuals, and we found that a total of 1,820 deaths were reported of the 13,000 plus patients that we had at our center. We tried to tease out the deaths in the older persons, and we found that there were 107 of these people who had died, 107 of the 1,820, that's about 6% of the total deaths were of those individuals who were more than 60 years of age at the time of registration for HIV. When we tried to study further the proportion of deaths, we find that those who were older than 60 years, of the 353 registrations, 107 had died, which is amounting to a 30% mortality rate among the 60 plus individuals. Among the younger individuals, we find that 1,713 of the 12,976 had died, which is about 13% in the younger age group. And this difference in death rate was proportional, and it was statistically significant by using a chi-square test. And we find that the p-value is less than 0.001 between the two groups. This histogram shows the frequency of deaths that were reported across the different years in our data. And yes, we can see that the death rate is kind of coming down after 2014, when the most deaths were recorded, and the therapy is probably becoming more effective in these last few years. We tried to study the baseline CD4 counts at the time of diagnosis of the population, and we find that in the entire subset of the population, the mean CD4 counts at the time of presentation were 335 per cubic ml, whereas when we try to see the difference between the younger age group and the older age group, we find that 337 per cubic ml is the baseline CD4 count among the younger individuals, whereas in the older persons, this was 252 with a 95% confidence interval of 229 to 275. And in a t-test, this difference was statistically significant with the p-value less than 0.0001. what is the change in the CD4 count after starting antiretroviral therapy. And we find that a total in the entire population, the delta change that we found was mean at 171 per cubic mm, whereas in the younger individuals, this was 172, while in the older group, this was 109. And again, this difference was statistically different and significant. We found that there is a difference in the increase in the younger group and the older group by at least 63 per cubic mm in starting heart treatment. So we concluded that more older persons were using the ART services at our center over the decades. More older women are also now using the ART services as compared to previous years. We notice that mortality is significantly higher in older individuals living with HIV. The baseline CD4 counts are lower in older persons, and the increment noted after starting antiretroviral therapy is lower or lesser in older persons. So our work tries to help us in trying to understand the epidemiology, the risk factors, and the mortality associated with HIV in older adults. Our observations are a reflection of the trends in the use of ART in older persons. And we also notice the age-related differences in the immune response after starting ART. This study and our results will help guide interventions in care and in resource allocation, adjusting for the trends observed for vulnerable subsets of this population. With this, I come to an end of this presentation, and I thank you for your patient attention.
A very warm hello to all the delegates attending the 22nd World Congress of Gerontology and Geriatrics, the IAGG 2022 World Annual Conference virtual. As part of the symposium on assessing the burden and impact of human immunodeficiency virus on older persons, I, Alpana RAIZADA, would be taking you through my talk on HIV in older women, the bitter half. A quick brief on how the demographics of HIV have shifted through the years. At the beginning of the epidemic, it was largely a disease confined to younger men, and it was these younger men who received all the attention in research as well as in critical care. Over the years, the feminization of this epidemic happened more so in sub-Saharan Africa than in the rest of the world, to the extent that by 2016, around 50% of all people living with HIV were constituted by women. Commensurate to this increase in the population of women with HIV, research and clinical care was guided towards females of reproductive age group. Thereafter, over the years, now what we are witnessing is a boom in the number of older people who are living with HIV. These numbers have been increasing at a rapid pace because of the initiation of highly active antiretroviral therapy, as well as improvements and advances in healthcare facilities in general. But unfortunately, the pace at which this population is growing, at the same pace, research and clinical care and targeted interventions for them are not keeping pace. So, as all of you are aware, that the data on people living with HIV in the 50 plus category is scarce. And the reason is that most of the high prevalence countries are doing population-based surveys which target females of reproductive age group through antenatal clinics and otherwise younger adults from ages of 15 to 49 years of age. So the pace at which the population is aging it's so fast that this has never been before. And parallel to this increase in the population of the aged, we have a rise in the number of people who are living with HIV over years of 50. Now, they used to account, let's see what is the quantum of the burden or the burden of having PLHIV over 50 around the globe. So in year 2000, they accounted only for 8% of the cases. As time progressed, by year 2016, this had progressed to 16%. And as of today, 21% of all PLHIV globally are more than 50 years of age. Now, this boom was, there have been countries like the developed countries like United States of America, which report that 50%, not 21%, 50% of all PLHIV in their countries are currently even more than 50 years of age. And another decade, these numbers are projected to reach to 70%. And it's not just that, half of them are being accounted for by women. In another decade or so, the low and middle income countries would also follow suit. And thereafter, what we will be witnessing would be a dearth of trained geriatric care as well as HIV specialists who would be required to take care of this explosion of PLHIV 50 plus. So did all of them acquire HIV after age 50? No. Many of them acquire HIV after age 50. This can be seen by the incidence figures. So 17% of all new infections which occur around the globe are because of people who are aged more than 50. Another very alarming fact is the late presentation. Because of ageist stereotypes, most of these patients present very late, and 35% of those aged more than 50 years, they present with advanced HIV or AIDS. Since this talk is about women suffering from HIV and those who are above 50 years of age, let me share a few statistics regarding trends of HIV in females. So in the 55, in the more than equal to 55-year age group, the rate of infection has increased. So for most of the other subsections of the population, these rates have shown a decline. However, for females, these rates have increased by 7%. If we look at this is in comparison to their male counterparts who are similarly aged. Now, if we look at the 45 to 54-year age group, the decline in the rate of infection has been slower by 8% than men who are similarly aged and suffering from HIV. So it's 14% for women versus 22% for men who are suffering from HIV and are above the age of 50. So why are women living with HIV 50 plus termed as the bitter half? So let's see why I call them the bitter half. A major reason for this bitterness is from the fact that they are born as women. With due regard to all those who believe in and who champion the cause of gender equality, the Equal Measures report clearly states that there is, as of yet, no country on the globe where gender equality is complete, is 100%. So by virtue of being born women, they have a disadvantage in this society. And why do I say so? This is because these listed causes, these are all inequities which are common to women around the globe, not just with HIV, but yes, with HIV, life becomes a little more difficult. So there are lack of protective laws. And in countries where these protective laws do exist, there is failure of optimal enforcement. On the other side of the spectrum, we have countries where the laws are restrictive. So these restrictive laws, they deprive the women of the decision or to keep the control of making decisions with themselves. Discrimination in educational and economic opportunities are there even in the most developed countries of the world. And this puts all women, and especially women with HIV, on the back foot. Non-availability of comprehensive sexual education is another major factor and is a major inequity, basically, which is common to all women as well as to women with HIV. There is a difficulty in accessing dignified holistic health care. When I say dignified and holistic healthcare, I mean that it is healthcare where there's no discrimination, where it is not being stigmatized. And by being holistic means there is a complete package of services which are offered, both in terms of physical health, emotional well being, mental health, and a social support system as well, coming from the healthcare sector. Unequal power dynamics, I have tried to not deliberately put it down, but I've just tried to put it at the end of the list because I want to stress upon and I want you to remember that unequal power dynamics is a very big factor which is affecting women around the globe. And you would be surprised to know that a 1% increase in the decision making power or a shift in power dynamics can lead to an increase of about 10% in the health utilization services by women. So, by just giving them 1 more % extra decision making power, or by altering the power dynamics by just 1%, the access to healthcare can be increased, or the utilization of healthcare could be increased by 10%. Intimate partner violence, or IPV, is a very, very big issue, which in COVID times also has been seen to take a very, bigger role. So, intimate partner violence is not something which is sacrosanct only to women with HIV. 35% of women around the globe have reported being subject to domestic violence by their intimate partners sometime or the other. So this is something which is again requiring a legal, input, and this underlines the need for revamping of societal norms, and not just societal norms, political motivation and enforcement of laws, so that women in general and women with HIV can all live a dignified life. Now, what are the inequities which are specific to older women with HIV? So, this bitterness just is on account of being a woman? No, the bitterness is extended. The bitterness is actually compounded by suffering from HIV. Majority of the risk reduction programs around the globe do not target older women, and if you try and do literature search, you'll find it actually difficult to find too many research articles which are exclusively dedicated to older women with HIV. So it has been largely a subsection which has not really been looked at, because, yes, the world was busy at targeting the younger population, the young adults. And why not? Because they were responsible for majority of the incidents of HIV. But now time has come when we are practically have put a control to new infections by and large. It is simultaneously very important that these people who are aging with HIV, they are taken better care of. So, what are these inequities which are specific to older women with HIV? A major inequity is their gaps in knowledge. They are not knowledgeable with terms of as far as HIV prevention, control, and management is concerned. So there are myths and beliefs. Plus, there is a general notion amongst women themselves that once they've attained menopause and once they've attained a certain age, they're unlikely to be at risk for pregnancy. So condoms which are worldwide used and propagated to decrease HIV transmission as well as to decrease the risk for sexually transmitted infections, they are not as much used by older women just because they think it is not essential because they're not at risk for pregnancy. Also, there are women who do not or who are not in a position to negotiate for safe sex as far as this pre-exposure prophylaxis is concerned. Most of the women, older women with HIV, they do not really have information about pre-exposure prophylaxis and neither do have access, and thus they are at continued risk of HIV transmission, especially where there are discordant couples. And this lack of condom use plus the very condition of the vagina in the perimenopausal time, which is thinned out and dry, all these lead to enhanced risk for transmission in elderly or older women. Another major factor is the ageist attitudes of healthcare providers. This is something which we can directly work upon. So most of healthcare providers would have this attitude that older people do not indulge in sexual activity. Even if they have that belief, they're somehow very uncomfortable with inquiring once they have such a patient coming up to them. At times, they confuse the symptoms of HIV with being part of a process of normal aging. So they do not even ask them to get routinely tested, and they are somehow very specifically left out from most trials which occur around the globe. They are also excluded from information, education, and counseling services. So these ageist attitudes of healthcare providers need a change and a training in geriatric care, and specifically in geriatric HIV care is again required. Stigma is part and parcel of suffering from HIV. But older women with HIV, especially those who have contracted HIV after the age of 50, they face larger stigma. This stigma leads to lack of disclosure to their spouses as well as to the family. And this basically becomes a big deterrent in access to healthcare services. They are often isolated, and depression is very common in this age group of women. Social challenges, of course, cannot be undermined. Women with HIV are in parallel to women around the globe who do not have HIV, they live a little longer than men with HIV. So there are a lot of women in this age group who have either lost their spouse, or who are divorced or separated, and who are currently not even taken care for by an active caregiver. And so they are facing a lot of loneliness. To the other side of it, if you see, some of them are faced with caregiver burden, where they themselves do not have a caregiver, but they are acting as caregivers to an ailing spouse, to an ailing child, or even more to grandchildren, where the younger ones have either left them to their fate, or they have actually, succumbed to their own diseases. Poverty and unemployment, these are two big social challenges which can actually multiply most of other challenges. So it is extremely important that they are suitably occupied, they are suitably employed, and some intervention, some social support system is generated specifically for women who are living with HIV. Coming on to, are there any unique medical concerns? Yes, there are a few unique medical concerns as far as women with the HIV in the age group of plus 50 are concerned. Let's see what they are. The list is not all comprehensive, and for shortage of time, I've just enlisted a few of these unique medical concerns. So there have been inconclusive reports connecting HIV and menopause. Yes, there is some data, some studies which show that women with HIV have earlier menopause than their non-HIV infected counterparts. Menopausal transition per se is a very difficult time in the life of a woman. And for a woman who's already suffering from HIV as a chronic disease, a lifelong disease to carry, plus multiple comorbidities as part of the normal aging process, this menopausal transition can be extremely difficult. Other comorbidities, yes, they are not exactly a unique concern, which is specifically for women with HIV. But yes, there are studies which show that they are at heightened cardiovascular risk, and they show more age-related immune decline. The prevalence of osteoporosis as compared to their HIV negative counterparts is pretty high in females with HIV. And because of early menopause, along with now the added longevity of their life, it means that they have many, many years to live with a musculoskeletal compromise secondary to osteoporosis, which is a major factor which adds to inflammation and to frailty per se. Neuropsychiatric changes are part and parcel, and a substantial number of patients suffering from HIV do have neuropsychiatric manifestations. These are more pronounced in women who are aged more than 50. Another concern, which is absolutely unique to women and very pertinent for women aged more than 50 with HIV, is the increased risk of invasive cervical carcinoma. So it is important, keeping in view the multiple comorbidities which are secondary to the normal aging process, opportunistic infections which are there by virtue of being HIV positive, the continuous inflammatory process of being suffering from HIV, the number of antiretroviral drugs and other drugs which they are expected to consume on a daily basis, the drug-drug interactions, the heightened effects of substance abuse agents like alcohol in women, all these together make a very complex situation. And a woman with HIV more than 50 per se is a very complex patient for any physician to treat. So, is there no way ahead? Of course, we have done enormous work in bringing this HIV epidemic under control. So, definitely, there is a way ahead for women with HIV plus 50 also. What is required is a contextualized care. When I say contextualized care, I mean it has to be taken keeping in context not just age and gender, but also race, ethnicity, comorbidities, socioeconomic conditions, their their political effects on where they are staying. So a lot many things are to be taken into consideration, and prevention and awareness, of course, is the backbone and has always been the backbone, which has mm, helped us take the big stride which we have currently taken in terms of controlling the HIV epidemic. Another important thing is that women by nature are more hardy, more resilient. It is important that these positive attributes of women, we need to build upon them so that they become more self-efficacious, more self-dependent, and they are able to lead their lives with a positive attitude. A multidisciplinary approach, that is a multi-pronged approach, wherein HIV-related services are linked to non-HIV-related services, and they are all provided in a holistic manner to a woman suffering from HIV. This is, the need of the hour. It is there can be nothing which can be gained in today's times if there is not enough political motivation backed by a solid legal cushion, and of course the commitment of the society to eradicate AIDS and to give the people living with AIDS a stigma-free and discrimination-free environment, nevertheless, can never be overemphasized. This is definitely what is required in today's times. So, in a nutshell, there are increasing numbers of older women with HIV. They're typically, up till now, being ignored or less represented when it comes to dissemination of information, education, and counseling services. Their concerns have largely been overlooked by risk reduction programs. Societal stereotypes have always been, compounding the HIV stigma, and we need to work definitely about it. And even our healthcare system, it is failing to provide a holistic, dignified care. This can be because of dearth of trained manpower, but yes, an entire change in outlook or attitude is required. And it is extremely important that we learn to link our HIV to non-HIV services. So I would just like to conclude by saying that leave no one behind. And it is extremely essential because inequality breeds transmission and equality feeds elimination. So if at all we are to eliminate AIDS from our society, we have to eliminate inequality, not just inequality of numbers, not just inequality of services, not just inequality based on gender or age, but inequality in all other terms as well. So we have to transition now, and this subset of population are women living with HIV in the plus 50 age group. They are currently the unseen, unheard, and unserved. We as physicians, we as geriatricians, we as a society now need to give them an inclusive, comprehensive, and dignified care. I would like to thank you for your patient hearing, and at the end of the session, would be glad to take up questions.
Dear colleagues, greetings from India. The topic of my presentation is HIV and non-communicable diseases, challenges in elderly. We all know that world is witnessing a dual disease epidemic of HIV and NCDs. And this is leading to the prevalence of more older people in HIV population pyramid. But only 1 in new HIV infection occurs among people aged 50 years and older. Rest of the infections, rest of the patients, they are infected in their either youth or the middle life. This slide shows that the life expectancy of HIV patients is reaching up to the life expectancy of non-HIV patients, as this is apparent from the various graphs: pre-heart period, early heart period, and the late heart period. In the late heart period, there is a negligible difference between the mortality of HIV infected and the non-HIV person. HIV, which was a life-threatening disease once upon a time, has become a manageable chronic condition now. And similarly, the non-communicable diseases are growing problem in the HIV patients as they are living longer on successful ART. The non-communicable diseases otherwise also increase in frequency with the age. They may be present before HIV or may be made worse by the HIV or ART treatment. So it's a triad of HIV virus itself, ART, and the traditional risk factors which come into play because of the aging population that increases the prevalence of NCDs in HIV patients and will become the leading cause of death by 2030. What the effects of HIV aging are there on the HIV? HIV accelerates the aging process itself. Aging and HIV have a drastic effects on the immune system of the patient, and they leave the older person susceptible to a stage of a chronic immune activation. That is the stage of hyper-responsiveness and energy to a antigenic stimulation. Moreover, the system recovery after treatment is slow in the older adults compared to the younger ones, and the rise in CD4 count is also less rapid compared to the younger adults. And we know that low CD4 counts are associated with the increased risk of the comorbid conditions. Non-communicable diseases are also having a global burden, and this is expected to reach up to 76% by 2030. And out of them, 36 million deaths per annum are going to be there, and most of them, 80% of them, are in the developing countries. And what is alarming is that these deaths will occur at an earlier age. So this prematurity is an alarm, as has been announced by the WHO 2015 report. And the non-communicable diseases are going to be a source of a morbidity and mortality in these developing countries where there is already a high burden of HIV and tuberculosis both. That there is an increased prevalence of non-communicable diseases is through the trimodal pathway. First is there is an increased life expectancy due to ART. The people are living longer because of the successful ART treatment. Second is the HIV infection itself. It will increase the risk of developing non-communicable diseases in these patients. And some ARTs are thought to have the effects which increases the cardiovascular risk factors and the risk of the comorbid conditions. The metabolism is decreased in the older adults. This is additionally in the aging patients, and there will be more toxicity. HIV infection and heart is associated with the obesity and the obesity, which becomes a risk factor for the various comorbid conditions. The persons of PLHIV who are at risk for NCDs, these are the persons who are being diagnosed late due to some or the other reason, or they are put on the older ART treatment as the effectivity differs and the safety profile also differs, and the older persons who has not achieved the optimal immune recovery time, these are the patients susceptible for NCDs. The trend of HIV-related morbidity is also changing. Now from 2000 onwards, the morbidity and mortality is more because of the increasing number of non-communicable diseases, which was earlier period, it was because of the opportunistic infections or the mortality because of the HIV or AIDS itself and the hepatitis B and C. Hence, there is an urgent need of integration of HIV and NCA and non-communicable diseases, as has been said by the UNAIDS coordinating board, and it has been found that the persons aged 50 years and above will increase to 95% by 2030. So this is an alarming rise. As far as pathogenesis of non-communicable diseases is concerned, the pathogenesis is again a tri-pronged pathogenesis. Either the patient factors or the virus factors or the treatment factors. Among the patient factors, it is the individual patient's susceptibility, such as the gender of the patient, genetic susceptibility of the patient, hypogonadism, menopause, apart from the other traditional risk factors which are ongoing in the patient, such as hypertension, diabetes, dyslipidemia, obesity, etc., along with the poor care and the poverty in the developing countries. The treatment factors are the ART treatment and their toxicity or the drug-drug interaction, which is more important in the elderly population. Virus factors are the HIV virus infection because of the viremia leads to the cascade of events of inflammation and immune activation, which ultimately leads to the endothelial adhesion, dyslipidemia, and hypercoagulation. And this has been very well demonstrated in a very important study, that is a SMART study, which says when HIV is uncontrolled, there is more of inflammation, more of endothelial damage, and there is an increased CVD risk. And it has been found this morbidity and mortality is always more in the patients, those who have been randomized to either no treatment or an intermittent treatment compared to a patients who were put on the continuous treatment. So it says that, again demonstrates that HIV viremia itself is an increased risk factor. These are the various common non-communicable diseases which can be seen in a patients of HIV infection. I'll be dealing them briefly about their screening, management in relation to HIV, especially in the elderly population also. First and most important is the cardiovascular diseases and HIV infection, and there is a 1.5 to 2-fold increased risk of CAD and 4.4-fold increased risk of sudden cardiac death, and it can affect the all segment of the cardiovascular tree with various manifestations. But there is a relationship between the CVD risk in HIV and treatment is U-shaped. So initial first is the rapid decrease after starting the ART treatment, the risk decreases. Then over a time of period where there is a moderate increase, either because of traditional risk factors, persistent inflammation, or maybe because of the drugs. So the curve is U-shaped. The screening of these patients requires the calculation of the ACVD risk factor calculator, and according to the risk of the patient, whether patient is categorized into a high risk approach or a low risk approach. The high risk approach groups are the patients who have a high risk, such as more than 7.5, or the patients already having a diabetes, high cholesterol, or clinical evidence of ASCVD, even if the in the age group, not in the elderly age group. But patients in the elderly age group, even if they come into the mid segment of the risk, that is 3.5 to 7.5%, if they have a special HIV risk enhancing factors, CVD risk enhancing factors, such as which can be history of prolonged viremia, delayed initiation, non-adherence or failure of the treatment, metabolic syndrome, then these patients are categorized into a high-risk approach, and they are started with the lifestyle modification as well as lipid-lowering drug therapy. In a patient of a low-risk category, the patients are only advised a high lifestyle modification, and yearly assessment is required of the risk. Management is not much specific. We know the ABC, which are the lifestyle modifications. You have to avoid tobacco and alcohol, be more active, positive, choose healthy diet, control hypertension, diabetes, and lipids. The pharmacological therapy requires a lipid-safe ART, lipid-lowering therapy, and management of the metabolic syndrome and the diabetes by metformin. And avoid using abacavir in patients with the elevated risk of the CVD. This is not a safe drug. Next is the hypertension. The overall prevalence is 25.2, and this is more in the ART experienced patients. And this prevalence or the increasing trend is seen, which is associated with the ART and the older age of the patient. So more the age, more is the chance of the hypertension. Screening is required at the time of ART registration, once in 6 months, or whenever the patient is symptomatic. And the rest of the things, diagnosis, management are almost same as we treat a non-HIV person. Only thing is that ACE inhibitors, ARBs and thiazides, they don't have an interaction with the ART. But calcium channel blockers, they have some interaction with the two groups of the NRTs, ARTs, such as the PIs and the NNRTIs. And the guideline also says that the maintain blood pressure 140 to 90 if the person is less than 80, and if the more than 80, it has to be kept at the 150 to 90. Lipid metabolism is one which is very much affected by the HIV, and there are in different stages there is a different parameters which get altered. The early and the disease progression stage, the HDL and the LDL cholesterol decreases, and these are consistent with the chronic inflammatory state of the patient. Plus there is an abnormal HDL cholesterol metabolism in HIV infected population, and the low CD4 count, high HIV level is also responsible. In the late phase, there is the triglycerides and the VLDL, they increases, and this is associated with the high HIV RNA level. Lipid safe ARTs, we have to keep in mind, these are the various group of the drugs which are useful in the ART, and the ones, those which are colored in the orange, they are the lipid safe drugs. So whenever we have we found an increased risk of the CVD or the lipids are altered, we have to consider these drugs, changing of these drugs. I'll not go in detail of each drug. The overall treatment of dyslipidemia requires a lifestyle modification, and lipid lowering drugs should be started, because it has been seen that the statins will reduce the cardiovascular events by 44%. And the patients who has a lipid unfriendly drug or which affects their lipid metabolism has to be switched over to a lipid friendly drug. European AIDS Clinical Society recommends the use of the statins when the total cholesterol level is more than 190, LDL cholesterol is more than 115. And the preferred drug is the atorvastatin in the starting dose of 10 milligram OD. Thus, maximum dose can be up to 80 milligram if the patient is not on the PI group of the drugs, where the maximum dose is only 20 milligram. Simvastatin and lovastatin are contraindicated in the presence of PI groups of drugs. Fenofibrate can be added. A RAPRIVI trial is a very important ongoing trial which is evaluating the effect of the statins in all HIV patients for the reduction of the cardiovascular events. Another comorbid condition is the diabetes, and the overall risk of the diabetes in HIV population is 1.2 to 2-fold. Prevalence of impaired glucose tolerance is 18 to 35%, and prevalence of overt diabetes is 10%. Only thing what we have to keep in mind about in these patients is that HbA1c underestimates glycemia in HIV infected person, and this is apparent from this graph. At a level of 7.5 HbA1c, the blood sugar is 150 milligram deciliter in a broken line, which is a broken line is a control group, and it corresponds to the 7.5. Red line is the HIV group, and it corresponds to the 6.5. So there is an underestimation of glycemia by HbA1c in HIV patients. The screening is required at the time of ART registration, 3 monthly thereafter, or whenever ART are changed. Other parameters, diagnostic parameters remains the same as for the general population. Monitoring also remains the same, and patient has to be monitored for the micro and macrovascular complications. Management also, only the sulfonylurea levels are affected by NNRTIs and PI group of the drugs. Other drugs can be used. And another thing which has to be kept in the mind is that when the patient is on the newer drug DTG, dolutegravir, the metformin dose can be given up to 1 gram only. Beyond that, it cannot be given. The bone mineral metabolism in HIV. There is a 6.4-fold increased risk of low BMD and 3.7-fold increased risk of osteoporosis in a HIV patient, and this is again more in the ART experienced patients. Apart from the risk factors, virus and the ART, traditional risk factors come into very much play in this category, and they should be taken into consideration. Hence, the treatment management of the bone mineral or osteoporosis requires a primary prevention. The patient should avoid the tobacco, alcohol, should do a physical exercises regularly. Secondary causes of osteoporosis should be ruled out. And the treatment is by vitamin D and calcium supplements and the bisphosphonates. What is important is that it has been seen that whatever regime is used, there is a reduction in the bone mineral density in the first 48 weeks of the therapy, as well as there is no evidence that switching a ARV regime will reduce the fracture risk in those patients who have established osteoporosis. So what is important is that screening guidelines has to be strengthened in these patients, and these guidelines are these patients can be screened to the two guidelines, FRAX score and the DEXA monitoring, if that DEXA monitoring is available, because it is a costlier investigation. Most important is the FRAX score, which calculates the fracture risk of the patient. And what is practical approach is that the persons who come under the low risk or the high risk category, DEXA scan may not be advised. A person who comes in the moderate risk category, DEXA scan should be done to further calculate the T-score, and if that score comes less than -2.5, patient can be started with the bisphosphonates. The persons who are in the low risk category, they can just be kept on the vitamin D, calcium supplementation and lifestyle modification. The persons who are in the high risk category of fracture risk, and there directly you can consider using the bisphosphonates without a DEXA scan. A patient of HIV should be screened for the serum CKD, chronic kidney disease, by serum creatinine and proteinuria every 6 monthly, and depending upon the findings, the patient is categorized into low risk and the high risk patients, such as if the GFR is less than 70, UPCR is more than 500, patient had associated comorbid conditions such as diabetes, hypertension, CVD, hepatitis C. Then these patients, what is important is that they should not be prescribed with the nephrotoxic ART drugs, and most important is that NSAIDs use should be prohibited in these patients. Abacavir can be given, which is safe in these patients. Similarly, older adults with HIV are at greater risk of developing a cancer, and this non-AIDS malignancy is becoming the more common cause of the death than the AIDS-related malignancy. The patient should be screened for the cancer, such as a HIV male patient with anemia more than 50 years of the age. Fecal occult blood test, as well as, if required, sigmoido and colonoscopy can be done. Our elderly patient who is a heavy smoker, a low-dose CT test should be done to rule out the lung malignancy. But there is no role of PSA for prostatic malignancy. As the age advances, we all know that the polypharmacy is very common in the elderly patients, and this graph shows the patients more than 65 years of the age either will be on the 3+ or 4+ medications. So this should be kept in the mind whenever we are starting a ART treatment or other treatment, and drug interaction should be kept. And moreover, adherence also has to be imposed much on the patient, because the number of medications, as the number of medications will increase, the patient may forget or may be negligible or may be non-adherent to the treatment. I'll just few words about the frailty I would like to comment here, because it is seen that frailty is more common in HIV infected person than non-HIV, and as the age advances, this is more, and frailty is an independent risk factor in HIV. So frailty can be defined by these 5 components. If there 3 are present, then we define the frailty. And if the patient shows signs of frailty, out of all these, the patient has to be managed with multi-directional approach, which includes the nutritional support, metabolic control, and most important, the physical part. Exercises such as yoga or balance training exercises, nutrition, avoidance of the risk factors, social health, emotional support. These are all factors which has to be taken into consideration. Older HIV patients are more susceptible to negative mental health, similarly by such as depression, dementia, and Alzheimer's disease. Many ARTs also increases this risk, and as efavirenz has been found to have a increased prevalence of depression. And we all know depression can exacerbate the immune dysfunction which already the patient has. So apart from these factors, the mental health of the patient may be affected by the fear of stigma, rejection by family, financial insecurity, dependence, fear of disease, and death. So whenever there is all these factors, elderly persons, the more of a depression is seen, and this will cause the non-adherence to all medications and may increase the suicidal rate also. So prevention, the unsafe sexual behavior is the major risk factor for the HIV infection, whereas the unhealthy lifestyle factors such as unhealthy diet, insufficient physical activity, tobacco use and alcohol abuse are the major risk factor for the NCDs. Strategies for preventing HIV infection and NCDs are directed towards modifying these behaviors and lifestyle simultaneously for both HIV as well as for NCDs, and management of both focuses on the positive health behaviors. So to summarize my topic, addressing and integrating NCDs in HIV care is important as the burden of NCDs is increasing globally. People are now living longer with good ARTs. Effective preventive health promoting HIV care will experience more age-related NCDs with interplay of the traditional risk factors. HIV and NCDs poses more challenges in older persons because of immune dysfunction, polypharmacy, drug-drug interaction, ART toxicity, depression, and frailty. So how to keep aging HIV patients healthy? We must widen our management focus, strengthen the screening guidelines, enforce the lifestyle modification strategies, consider statins and bisphosphonates when needed, keep readiness and watch our comorbidities with initiation of the HART because they are going to develop more complications. Individualize suitable alternative regime if needed, and what is most important is that give them some extra time. Elderly patients are there. If you just give them 5-10 extra minutes, they are more comfortable, more happy, and more confident. Thank you very much.
Hello once again, friends. And with this, we come to the closure of this session. And I believe that by now you have heard all the three speakers in this session, where I first started off by describing the service utilization at our center. Then Dr. Alpana RAIZADA, who spoke about the bitter half, the impact of HIV in the women who are elderly. And finally, you also heard my colleague, Dr. Meenaxi SHARDA, who also spoke about the impact and the burden of HIV in the older persons. With this, we come to a closure in this session, and we invite, if there are any questions, we would be happy to handle and address those at this point of time. So please feel free to ask questions in whatever manner you feel convenient. Thank you so much.
Shall I ask first question? That was related to the better treatment for elderly with HIV. So rather than the drugs, which we have to individualize according to the patient's need and comorbidities, more important is the adherence of the treatment. Because by the time the patient becomes elderly, he has already some other medications, polypharmacy is there. So adherence is most important. Monitoring is important, and regular monitoring for the new development of a new comorbidities, and that way the better way it can be, better way the elderly patient can be managed. And the safe drugs we have to use according to the patient's comorbid condition. Second question, I think Dr. Alpana would like to answer. Dr. Alpana, would you like to answer this HPV vaccine?
Yes. So, though the HPV vaccine has been recommended only for women up to 26 years of age, but since 2018, FDA has increased the age up to which adults aged up to 45 years can also take HPV vaccine. And since HPV is not just responsible for causing carcinoma cervix, but for other diseases as well, so it is this can be taken up by HIV infected individuals who are up to age 45 currently. though most other countries, I'm not aware of whether they have included this into their programs or not.